So introductions. So we've met before. So this is the list of our CST team. So for those on our team, if you are going to be providing any support, please just introduce yourself and your role. I see that Esther's joined us. Great. So here's the agenda for today. We'll go through some design decisions, and then we'll do a provider follow-up, and then there is a portion where we will review forms and the gaps. We'll decide if we can take a break or just power through. We'll then dive into a nursing demo and review, speak through some allied health stuff, speak through downtime and forms, and then finish off with session recap and next steps. Okay, so the purpose of this session is to validate what works and identify any key gaps, to validate the standards and processes that will be configured in the new system that will meet your workflow. And then this is just a glossary of terms that we will be using. I'll just give you guys a few minutes just to kind of review. Please ask questions if we use a term that you may not be familiar with. We're more than happy to clarify. All right, so I'm just going to dive into some of our design decisions that we require decisions on from the group. So the first one is the core location name. So we're proposing that your core location name will be VGH Renal Peritoneal Dialysis Unit, and then the abbreviation will be VGH PD Unit. The abbreviation will be what's visible in the banner bar when you review your patient's chart. And then the longer core location name is visible when upon registration, when we have to search up for the organization. So just taking screenshots of what's currently built for St. Paul's PD unit, and we're just adjusting the same kind of naming convention.
That's not what our hospital unit is called at the hospital. Oh. That's not what our signage is. So we'll need to change that.
Okay, what is the signage?
It's the independent dialysis. Is it center or unit?
I think. Do you want me to run outside and check?
Yeah, I think so.
Let me check what's outside. Sorry.
It's unit.
It is unit.
Yeah, I think it's unit. It keeps flopping back and forth, but I think our signage says unit. The thing about it is that a lot of our paperwork and other areas of the hospital still have us as center. So there's like, we kind of bounce between the two, but our signage says unit.
So in Cerner, I think we had to split up PD and home hemo as two locations and build it out that way so that you can register and differentiate your patients. If we named it IDC or IDU, you wouldn't be able to differentiate between your PD and home hemo patients.
Yeah, that's right. So that's why
I don't understand that. They're registered in a different dialysis modality. I mean,
it's what we'll show on the banner bar. So the little blue box on the screen, when you look up the patient name, it'll say Mr. John Smith and his location is at say VGH. If it was IDU, it'll say VGH IDU, but you won't be able to tell if it was a PD patient or a home hemo patient.
So we're recommending building them separately in the system so the clinicians can delineate and know which patient belongs to which unit.
Yeah, and it's just following what PCIS does right now, where it does differentiate between PD and HD, home hemo. So the same way how the legacy system does it, and this is the only way you can differentiate. So overall, it's understood that PD and home hemo are under the IDU, but in Cerner, the way for people to know exactly which location and which modality the patient's in, we had to build it out as two separate locations.
This has implications for scheduling appointments as well. So building it out this way supports appointments that are scheduled for patients in this clinic, in this location.
Okay.
Okay, so are we okay with the naming then? So VGH Renal Peritoneal Dialysis Unit and the abbreviation of VGH PD Unit?
Yeah, that's fine.
Okay, great, thank you. Moving on towards the request list. So this would be what the clerk would see in their scheduling appointment book. So we would just need confirmation that the location will be okay with the abbreviation of VGH PD Unit. Is that okay?
Doesn't matter if we're calling it VGH PD unit, PD clinic.
I think
We are-
unit is fine. Unit is fine, I think, Dan.
Okay.
Yeah.
Just kind of being standard with St. Paul's, they just use the word unit as well. Okay. And then with the results queue, this is the work queue, the external facts. So understandably, with you guys sharing the space with home hemo and the same, just the one clerk managing the external documents that will come through. There's just a one fax number. So we are proposing that the queue name is reflective of the two units. So be VGH PD / home hemo or HHD. We did consider IDC, but then we don't recommend that because it may be confused with infectious diseases. So we didn't want to suggest using that.
Yeah, that's fine since you've separated PD and home hemo anyway. And so keep it the same terminology.
Yeah. So Esther, when you do receive external faxes, you'll see both for PD and home hemodialysis coming through in this one queue. Okay.
Okay, thank you.
Yeah, no problem. So ambulatory organizer, in Heather's previous scheduling requirements gathering session, it was identified that these would be specific resources that you have requested. So what I'm needing confirmation is just the name for the resource group. So I'm just showing you an image of what's built out for St. Paul's and their needs for their resources. So their name is SPHPD resource group, and these are the list of different resources built out specific for the St. Paul's unit. So given what was confirmed, you would have the resources visible here when you search up VGH PD resource group. You'll have your renal IDC procedure room, PD nurses number 1 to 5, and then just the general VGH PD MD resource. Is the group okay with the name VGH PD resource group?
If we had to get specific, shouldn't the PCC or educator be on there, or maybe in our case also the triage nurse?
Well, this is based off of what was confirmed with Heather in the previous scheduling sessions that you guys did together.
Yeah, so this will only include the resources that were called out that you need to schedule appointments to. So if we do need to add more resources, we can.
Got it. Okay.
Okay. So just being following a similar kind of naming convention for SPH, I'm just recommending VGH PD resource group. So hopefully the group's okay with that.
Well, I'm just gonna say I don't really like people being called resource, but anyway, it's fine. I guess if that's what's being done.
Yeah, so when you search for
I'm
it
not sure,
here,
like, how is this accessed? Like somebody is gonna search VGH PD resource group? Is that what's
yeah.
actually gonna happen?
Yeah, so through Ambulatory Organizer, there'd be a landing page for like say your nurses and as well as providers. So this allows you to view all the appointments a patient scheduled for the clinic that day. So you can view through like the various resources here, like the procedure room, the nurses, or just the general PD MD group. But the parents group name would be VGH PD resource group that you would search.
I'm just wondering, how about the patient care coordinator? Would it be also a part of the resource group?
Are you guys scheduling patients directly to see the PCC? Like, are you scheduling anyone to see Dan individually?
Really, I'm just wondering, like, if he need to access or.
Oh no, you guys will all have access.
Oh,
This
okay.
is just who is scheduled to a patient.
Okay.
Mhm.
And I
But is
noticed that the physicians are named, but the nurses and dietitians aren't named. Is there a particular reason why that is? Because the physicians may change over time as well.
Yeah, so then what I'm showing you is just what St. Paul's requirements were for their design and build of their resources. And then in a previous scheduling session with Heather, it was identified that these resources here in bold is what the clinic needs for VGH to be built out, to book appointments to.
I think the standard Cerner build is for physician names to just use the actual physician name for the resource. And then the recommendation for the rest of the staff is to just use generic names when possible, because yeah, and you're on the right, you're on the right idea around it. It's because if there are staff changes, it is a bit harder to update and change those resource names. But for physicians, most of the time, they're pretty.
Yeah, the only reason I asked that is, scheduling in the future, like 4 months, let's say if we're scheduling a patient to be reassessed in 4 months, we actually might not know which physician it is.
Yeah, sorry, I just want to jump in here because I was involved in gathering the requirements for scheduling, and we did have that discussion if we wanted to book to this specific provider or not. And in your scenario at VGH, it sounds like you have a rotating schedule of providers, and it doesn't matter who the patient sees. They see who's ever on rotation that week. Whereas at St. Paul's, they wanted the ability to book to the specific provider. They wanted the same provider to be able to follow up with the.
But at St. Paul's, they also have a different person who's scheduled for PD that week, whatever. Okay, but it's.
Yeah, but that's what they selected. That's
So
what works for
what
them.
but what I'm just asking though is what if they don't know what happens? Like if they don't know it's Dr. Singh or Dr. Copeland, then how is it scheduled? Because that's going to have an impact on all our schedules. It's going to show up in my schedule, etc. Right? So
they don't book a lot of appointments. Very few appointments are booked directly to the provider. And I believe it would be just requested from a follow-up order, and it would be one of the doctors requesting that the patient be booked to them at a specific date and time, and they would communicate that in the follow-up order.
So
But
for you guys, we just have a generic name.
This one here.
okay.
Mhm.
Can I ask for a favor? If you guys can also include the triage nurse. I can see in the future where we are actually going to be scheduling a patient to talk to a triage nurse, especially when it's a transitioning from PD to hemo and community, or it doesn't matter, or long-term care. We will be scheduling them on there also.
okay, I'll make a note of that and gather more information in the scheduling session next week.
And sorry, my name's Kevin, the pharmacist with PD. So I probably should have mentioned this in the last meeting, but maybe I wasn't there for that when the question was posed. But the pharmacist does see the patient on the initial week that they're training. And so that's like right now we have a scheduled slot as well, but that's the only time that we kind of need our own session. But it might still be worthwhile to have it on here so that it shows up on our schedule.
Just to clarify.
Sorry, go ahead, Heather. Go ahead.
So just to clarify with that, I was told in the previous session that the pharmacist would never be booked for a one-on-one appointment with the patient. They would maybe join on to an existing appointment. So are you saying that you would need to be booked one-on-one?
Well, that's true. Then I'll just, okay, then I'll just organize with the nurse then. Because I guess you're right. With the first week of training, I think patients are usually booked for 4 or 5 days, and we would just show up for an hour on one of those PD nurse sessions. But I guess it wouldn't make sense to,
That's what was discussed for all of the allied health and pharmacist resources, so that the patient will be scheduled to see the nurse as the primary resource, and then they would coordinate who else needs to come into that appointment.
Okay, no, that's perfect. Thanks for clarifying.
Great, no problem.
Does it hurt having extra positions on there? Like if we did add pharmacist on there, what harm is it by adding an extra name or position?
It just adds to the complexity of the scheduling, which is not a good thing to do. If it doesn't add any value on your end, it's only going to complicate things on the scheduling side.
I actually think it should be added because
So what?
Basically this is also like serving to track activity and that kind of thing in terms of scheduling for resources down the road, etc. So there are times when I think as Kevin mentioned, we should know exactly that a pharmacist has seen that patient and when they were reviewed and had med stuff done. So I'm not sure adding one line there is, I mean, I agree with Dan. I think it should be added in there. It's no different than having the dietitian.
Can I just ask, when the clerk is scheduling the appointment, will they know exactly when the patient is going to see the nurse versus the pharmacist versus the dietitian? Or is that kind of fluid on the day of the appointment?
it is fluid on the day of the appointment.
Yeah,
But
that's
then
looking at
if
in.
that's the case, how do you know which members of the allied health team have seen the patient that time then?
Flo, we're not using any type of tracking shell for this clinic, are we?
No, we're not, but
they will be documenting.
But
correct?
we're
Yes.
going through all this trouble of scheduling and having an idea of what like workflow is. So from our perspective, for our management, we need it. Whether or not you guys need it to do your tracking, it's two different things. This is supposed to be also for us, right?
So I'm hearing
So,
that,
Denise,
oh, go ahead.
it's Wayne here. There's one way that you can do it is like what we do in KCC and for our dietitians is we put in a referral to social work to dietitians. So therefore you can track the workload that way when they're seeing the patients. Like if you got your PD patient, you want them to see a social worker or you want to see the dietitian or the pharmacist, you pop in a referral and then they know to come and see the patient.
Yes, Wayne, does that require additional time for that workflow to put in a referral, get a response back and put it
No,
on?
basically, Dan, it's sort of, yes, there's a little bit of work in the sense of you put in the referral into the system, but then the dietitian or the pharmacist and whatever have a list and they can see when they've got referrals and they can go in and it's like their little work queue that they go off and go, okay, I've got to go see this patient.
Yeah, another option, I can easily add it to the scheduling if it does add value for statistics. And I can just make all of the allied resources, including the pharmacist, dietitian, social worker, as optional secondary resources. So when the clerk is booking the appointment, they can just book it to the nurse or they can check off whoever else needs to be involved in that appointment. And it will block them for that entire appointment. If we don't need to worry about this exact time frame, each resource is seeing that patient, then the scheduling won't be overly complicated. They would just check off that, yes, the social worker and the pharmacist are also involved in this appointment. It will block off their calendars as well, and you can pull the stats on that.
Yeah,
That
so
makes
there are several options, and the option that Wayne brought up is actually the enterprise option that is being used for all the allied staff and the pharmacists, and it's a simple way for them to keep track of their active caseloads and who they're seeing by putting in those consult orders or follow-up orders, and then there are reports that are built specifically to pull stats on how many of those were done, so you know how many patients the pharmacist saw within a month or which patients the dietitian saw and things like that. So that was kind of the workflow we were going to propose because that is the enterprise workflow.
So Flo, I just have a question about that. Like, let's say, because what we're talking about here is similar to a clinic visit. In a clinic visit, is each provider specifically assigned separately, or is it like one nurse resource that then refers to the rest of the allied healthcare staff? Or is it each individual person that's scheduled to see that patient in a clinic?
It's not, so the way, what we gathered the requirements for right now, it's not each individual patient scheduled for each clinic. I think you're kind of thinking of like how the kidney clinic schedules, you know, how they schedule to every single individual.
Yeah, but no, I mean by like PD clinic, right? Like at St. Paul's in the PD clinic, there's a physician, a nurse, a social worker, dietitian, pharmacist. How is it? So I would see what we're talking about here, this encounter during training, the same as that. So how is that listed? Like, is the pharmacist listed as an individual provider in that?
No, it's the patient will just be, no, the patient will just be booked for the training with the nurse. And then in the days that the patient is there training with the nurse, if anyone else is going to see the patient, they can put in their own follow-up order to track, or if you want it in the schedule so that they do show up, then that would be Heather's suggestion just now.
Yeah, and just to clarify, my understanding of Paul's is that they actually book the majority of their appointments to just the room A, B, C, D. The nurse resources are only there for off-unit appointments when the patient is not seen in one of the rooms. So they rarely book to the actual resource or actual clinician. They're just booking the patient into a room.
Can I
How
ask?
about, yeah, sorry,
What-
go ahead.
Has there ever been a day where they booked to a room and no nurse was there? Just out of curiosity. I mean, other than, I mean, like
No,
it's kind of a
yeah.
bizarre setting, but okay.
Because what
No,
happens
because
is
it doesn't matter what nurse goes and sees the patient. It's that's booked like for the training schedule. We know that there's a nurse on that particular day. So it's really just assigning out the spots. So we know we've got spots for the patient to be able to talk what they need to be taught.
That was a joke, Wayne.
I get it.
But when the patients are booked to a room, it shows up on the ambulatory organizer, like the time of their appointment, and then they get checked in, and then the nurses or whoever in the unit will just go and see the patient because they'll know they're in room A, B, C, or D. So that's kind of how it's done at St. Paul's. And correct me if I'm wrong, Wayne.
Yeah, that's correct. It's the 4 rooms that they're mainly booked into. And I can say the more spots that you have in ambulatory organizer, the more unruly it starts looking when you're trying to work out who's seeing what patient and what's happening.
Why does it still seem like it's easier if we just add the pharmacist in there? And when Kevin needs to see the patient during the training, he would just let us know it's Thursday, 1 o'clock, we enter it, done.
This is Vik. I think I agree with Dr. Singh and Dan. So it's better to put the resources as optional so that whenever they feel like having an appointment with any pharmacist or allied health staff, it is better in terms of capturing the statistics. So optional resources would be, I think Dan and Dr. Singh would be fine, I believe.
Okay, so what I'm hearing is that we'll look into adding additional optional resources, and we can discuss that in another scheduling session with you, Heather.
Yeah, of course.
Okay, awesome. Thank you. Good discussion here. Okay, I'm just going to move on to clinic flags. So flags in general in Cerner are used to identify patients who are being followed, or will be followed by a specific program. So in addition to that, clinic flags also allow the clinic itself to follow or track patients if they are registered to other areas at a Cerner site. So for example, if one of your patients gets admitted to Lionsgate ED, there is a notification that can be built out to send to your group to notify you. So what we're recommending for the clinic flag name is VGH renal peritoneal dialysis. And then this just follows the standard kind of naming convention for what we've built out for the PhD renal program, as you can see here. Would the group be okay with this name for their clinic flag? Not hearing anything, so I'm just going to take that as an okay. The clinic flag is applied upon registration, and it can be taken off or removed depending on the renal area that the patient may be moving around to. Okay, so then it just leads me into Message Center. So this is the Cerner equivalent of like internal messaging system between clinicians. So what I'm looking for is a decision around pools. So think of pools as like a distribution list. So we offer 3 different pools here. We have a clinical pool, which is comprised of nursing, allied health. There's an admin pool. This is your clerical, schedulers, et cetera. And there's a provider pool. So what I have here in this screenshot is a list of different pools available. St. Paul's PD only opted to create just one pool, which is just for providers. So I'm not sure what the VGH clinic would want or need.
So providers, as I understand it, is just physicians and pharmacists right now?
Mm-hmm,
that's the
right.
technical. So this is where, I mean, the most common messages are probably going to go to nursing. I think it should include the nursing provider and possibly probably the PCC as well.
I'm hearing that you want 2 pools, like a provider pool for all the PD providers and one for clinical, just for the nurses and clerical. Or sorry, allied,
no, I'm just saying that the providers, the physicians, are likely to be messaging less each other and more other members of the team. So it would, I think, yes, I would say a separate one just for the physicians and then a larger one with everybody.
Okay, so provider pool and then a clerical pool, clinical pool would, I'm just trying to think from an administration perspective, if there needs to be one for you, Esther, and other clerks in the unit.
What other clerks in the unit?
Yeah.
Just seeing if there's any other, like if there's like casual or anyone else?
No.
Okay,
Nope,
okay.
There's no
So I'm
casuals,
hearing,
no vacation
okay.
reliefs. No.
So just hearing the two pools, members can opt in and out. And from a naming perspective, I'm recommending that it be VGH, renal, PD, and then providers for the provider pool, and then VGH, renal, PD, clinical for the clinical pool.
Right, and that clinical pool will include the admin. Is that correct?
I'm gonna look to my team. I don't think the clinical pool type can have clerical staff opt in to that.
Because I'm just, correct me if I'm wrong, but we're talking about a message center that we can all look at to send messages to each other. Is that correct?
Yeah, so these
So the
pools are.
provider has their own pool so that they are just messaging between providers. Then we have another pool where the provider and the clinical is incorporated in the same messaging. But we can't leave out the admin. So
yeah,
there's a lot of messaging that Esther is included in on. So I'm just wondering.
Because you can still like send messages directly to Esther. It's just that these pools are, think of it like your Outlook distribution list. They're just groups of individuals into this one group. So you send it to the pool and everyone in the pool will get the message that they need to hear or read. But you can still send direct messages to one another. So Esther can send a direct message to you, Dan. You can send a direct message to Dr. Singh. So it's kind of like, yeah, it's just like the email version, but on Cerner.
Marisa, I think we can add admin pool as well, and we can have PCC and clerk and maybe the charge nurse. Dan, is it okay?
Yep, I think we could.
I'm hearing that you guys want 3 pools then, a clinical admin and a provider pool?
Yes.
I think that just makes it a little easier for us to understand who are messaging and including which groups. So
okay, because I'm just thinking from an admin pool, if it's just Esther, I don't know if you want to build a pool just for her. She'll be the only person in the pool versus just sending her a direct message.
Yeah, but we don't know what the future holds.
Okay.
There may be additional people in that role.
Okay. Okay, sounds
thanks,
good.
Vic.
And then the last thing I just wanted to ask is with the clinic flag I introduced, if one of your patients with the PD clinic flag gets admitted to a different hospital, like in the Cerner system, there is a notification that can be sent by message center to one of these pools. We are recommending that it just goes to maybe the clerical pool, and then the clerk can just notify the unit that, say, a patient may not show up for their appointment today because they're admitted somewhere else in a Cerner site. Would that recommendation be okay for the group? This notification can only be sent to one pool.
Hi, I'm Chris. I'm one of the PE nurses. The problem with that is if the admin pool is not present, which is only Esther, we will not be able to receive it, right?
That's fair, yeah. Would the clinical pool be a better alternative then? Okay.
Be to other groups so that there's not only one person manning it.
Okay. Great, thank you. Oh, and just lastly, each pool kind of needs like a team lead. It's just to ensure that there aren't any clinicians that are opting in that are inappropriate. So for each of your pools, who would be an appropriate team lead?
Admin, I recommend Esther.
Okay.
Yeah, don't put a physician as the team leads because they don't check it.
So for your clinical pool, would it be you, Chris, by chance? You want to
And
be the team lead? And then provider,
Do you need a name or just a position?
you can give me a name, that'd be great.
Dan, I used to have them for all of my areas because people were opting in and it's like, you shouldn't be getting this patient information.
Okay. So Wayne, you're the team lead on that one, right?
Yeah, I was the team lead actually on nearly all of them, I think it was, because I would just review them. It's like an email distribution list and stuff like that. Like I would just review them and going like, why are you in this? This is patient private information. You shouldn't be getting it and checking in and stuff.
Good. Now, Marissa, can we add 2 names or is it just one name is all you need to add?
Just one name,
There's-
I mean,
Yeah,
Then if you could put me on that for now. Yep.
for the provider?
For the team
Or
lead.
For the, okay. And
I
Chris,
would
you're good to
recommend
be,
Dan for all of them. Would be my
okay.
recommendation.
You'll be okay with that, Dan?
Sure.
Okay,
Because I mean, it'll be the charge, the PCC or whoever does it. You know when new staff are coming in and staff are leaving, so you just update your pools when that happens.
Okay.
okay.
Thanks. Thanks,
And
Wayne.
can I ask a question here? I just want to clarify. This message center is the same one that like orders would come to physicians from nurses and stuff like that, right? It's not a separate message center?
No, just the one, that's right.
Oh, this will be fun. Yeah, okay.
It sounds unruly, but if you stay on top of it, and it's what I would say is message center does not replace communication between a physician and a nurse and everything else. It's really about the non-urgent stuff that you can send through and going like, these results have come through that you need to review, and you can tag it to Sunit and then she'll see it and click straight on it and go straight to it. The nice thing about Message Center, it can become part of the patient's medical record. So don't use it as email communication. It should be factual as such.
Mhm. Yeah, thanks, Wayne.
Thanks, Wayne.
So some of our teams have developed up templates. So when they're communicating to the physician group, it's sort of a template of what the issue is, what they're wanting, and whatever needs attaching to it.
Mhm. Okay, gonna move
Quick
on to the
question.
next. Oh, yeah, go
if,
ahead.
for example, Dan is not around and then we will not be able to see anything.
You'll be able to see it. It's just Dan has the administration rights over adding people in and taking people out. But
Yeah,
you can
that's right.
opt
Okay.
into them yourselves.
Yeah.
And that's why you need an administration person at the top basically going, why is this person in here? Because they do.
Okay.
Mhm. Yeah.
Thanks.
Okay, just going to move on to the referral to outpatient PD order. So just wanted to mention that this is used by clinicians at Cerner sites to refer to your clinic. So this would, just a screenshot of what the order would look like. And I just need to ensure that the scheduling location, the location here would be appropriate as VGH peritoneal dialysis. Just follows the same build for what we have for St. Paul's. Make sense? Okay.
Yep, that's good.
So I did want to talk through this PD IV infusion. This was a requested new appointment type from your scheduling session with Heather. I wanted just to get some more information to understand what is infused during this appointment currently in your clinic.
Sorry, ask that again. I missed that.
Yeah, so there are PD IV infusion appointment types that you currently
Yep.
have. What type of
Yep.
infusions are you infusing right for those appointments?
Iron or blood makes up 95% of it.
Okay. The reason why I'm asking is because there are available appointment types built out to specify different infusions, and we were wondering if any of those existing ones could be leveraged. So you'll just see that screenshot here. So you mentioned there was
Well, there's
iron.
the two irons there, which is iron isomalt and iron sucrose. So those would be. And then is there a infusion there, blood anywhere?
Yeah, so we do have separate transfusion appointment types. Would it make sense for me to review this list in the scheduling session with Dan and Esther and Pam?
Sure, but what you've got there seems to be more the short stay thing, which is probably almost never applied to the PD population.
Okay, so, but you do some iron infusions in the actual PD unit?
Yep, iron and blood, yeah.
Okay.
Okay.
And
What
magnesium.
kind of,
Sorry?
so what kind of transfusions do you do? Is it platelets or red blood cells?
Mostly red blood cells, but we could theoretically do platelets, yes.
Okay, I'll review the full list of transfusion appointment types in my session, but we do have separate appointment types for both platelets and red blood cells that we can leverage.
Okay, great. Thank you.
Thanks.
So I just want to prime the group. So the next few slides, I just wanted to talk through like appointment types and how they're linked to specific orders in the system. So what you're seeing here is your follow-up order. This would fall into the request list for the clerk to book the appropriate follow-up appointment. So what we see here in these green boxes are the appointments that were discussed in that scheduling session with Heather. So these ones are specific to what the needs are for the VGH clinic. So in this appointment requested drop-down box, all of these appointment types will be available for selection when this follow-up order is placed. So why I'm bringing this up is because what it's currently built out right now for St. Paul's is that you have certain appointment types linked to this follow-up order, but then there are also other appointment types that are linked to procedure orders in the system. So I'll just kind of show you what they are, and then I have some screenshots to kind of help support the conversation. So these are your specific VGH appointment types. So these first three here, what we have built out for St. Paul's right now is that they're just linked to standalone procedure type orders in the system. So if I were to look for leak test, then if I entered in the system for a patient, it would have a PD leak test appointment type, which would fall to Esther's request list to book this specific appointment. But then there are other specific appointment types and their associate orders that are found in specific PD power plans. So this is what it looks like from a power plan perspective. So this is the example of the intermittent peritoneal dialysis power plan, and within that are schedulable orders. So this would also fall into Esther's queue, and she would book the appropriate appointment type for the patient to come back to the clinic for. So what we really need to understand to ensure that the build meets your needs is, do appointment types need to be requested outside of the PD unit location? Maybe I'll start with that question.
Yep, we do. We also do the CBC removals, CBC flushes here. So those will be requested outside the unit.
Okay. Okay. All right. And then to follow up with that, with the scheduling related orders, there is a scheduling location, and I just need to confirm that it would be VGH peritoneal dialysis. There is one order that I will call out would be a little bit different, but I'll get into that in a different slide. Would it be appropriate that they would be, these appointments would be scheduled to this location, the VGH peritoneal dialysis?
Yes. No.
Okay. Okay. So this is
Right.
just another, yeah, sorry, go ahead.
All right, I was just wondering if you could go back to the follow-up order and if we could clarify any of those appointments. So just to clarify, the follow-up order can only be requested on a VGH PD encounter. So the purpose of this order is to request appointments for a patient that you're already following. So we just need to confirm that none of the appointment types in those yellow greeny boxes there would need to be requested on another encounter. So would any of those appointment types ever be requested on an inpatient encounter, for example?
Yeah, so if a patient goes to, let's say, Lionsgate or St. Paul's, or a VGH PD patient, and they have peritonitis, and they get initial treatment there, and then would the St. Paul's clinicians request a follow-up with us? They would, right? So it would be coming out of.
Would they not need to refer the patient to you first?
But that's already our patient.
Even though they're being followed at another site?
But they just had to make an emerge visit at another site, and then they need a follow-up with us.
Flo, maybe you can help me out here. Wouldn't the workflow be that if they were seeing an emergency at another site, the first step would be for them to be referred to the VGH PD clinic. And then from there, they would decide what needs to be done. So they would have that initial assessment with the patient first.
I think what Dr. Singh is saying is their existing chronic PD patients end up and emerge somehow and got brought to Lionsgate. And then they're identified, oh, you're a PD patient at VGH, but they're treating them at Lionsgate Emerge for now. Or at St. Paul's, they could easily be sent to St. Paul's Emerge too. And they're treating them there. And then after they're discharged, they need to go back to VGH and have a follow-up. So who would be ordering that? Or how would that happen, the communication?
That wouldn't be a unique workflow to VGH. Do you have any idea how that works at St. Paul's currently?
Well, actually, I was just going to ask Sunit right now, when we have a VGH patient that comes to us, how do you get notified that, like, to follow up with the patient?
We don't.
We don't always.
Yeah.
Often it's just like a text from one of the providers saying, hey, oh, this patient was here. Can you see them?
Yeah. So in the new system, you will get a printout every day because they'll have a clinic flag attached to them. So you'll see when they've been into St. Paul's or Lionsgate, and it will come out on a printed report every morning. So you'll be able to see if I've had an emerge visit or anything else. This will be a new step for us if we want to do the referral piece. And it's really not a referral as such. It's like, you probably should see your patient. They've been admitted to, they came into St. Paul's with peritonitis. They've received their antibiotics. Yeah, it's more of a, it may come through message set. We might want to do it through Message Center, or we might want to do it as a referral piece. It's going to be a new process.
Yeah, I'm just thinking that usually the, a discharge, the team that's discharging a patient and wants a patient to have follow-up, they usually sort of give some idea of the follow-up, because we might not know everything that happens to that patient, right? So for example, if you saw a VGH patient and they had antibiotics organized for 3 days already, then we would schedule them for the 4th day follow-up, right? So part of our thing would be for the discharge team to kind of say this patient has been discharged and stuff. Are you saying, Wayne, that I'm going to get a note every single day on that patient?
You won't get a note every single day. So there'll be a printout page that basically shows all the patients that have been admitted that have the PD clinic flag, either to Lionsgate, to Seashell, to any hospital. You'll get to see that clinic flag. And so you either look at it, ignore it, whatever you want to do. Like usually our teams look at it, like the nursing staff, so they can see that the patient's in there. And then you can see the medical record of what actually happened.
Yeah, so basically you'll get a notification whenever one of your PD patients is admitted somewhere. And when you get that notification, that's kind of what's going to prompt you to go into the system and look up the information of their admission.
Okay. I'm just saying that I doubt currently that any of the clinicians are looking into the records regularly of a patient who's admitted to another hospital. So they're only going to pay attention. They're only going to pay attention if they're called specifically about a question. Or, I mean, I might have 15 patients admitted to other hospitals. I do not go into all their records. I rely on a discharge summary. And then I would expect that discharge team would request a follow-up, right? Because I'm not going to go and check their record every day. I mean, that's just.
No, I think this is a new workflow that we just need to work on now, Sunit, that we're going into Cerner. And this is one way that we can do it. Is when that, let's say they're admitted here for cardiac surgery or whatever, and then the PD team or the consult team would put a referral back to you guys to say, hey, they've had cardiac surgery, here's an update.
Right, I think that's the best way to put that referral in. Yeah, thanks, Wayne.
Yeah, I think this is just going to be a new workflow that we're going to have to work on between our areas. The outlier problem will more than likely be like Lionsgate and other hospitals, because they may not know how to use it appropriately. We can teach within our own renal programs.
Right, but I mean, I guess the thing is that they somehow have to communicate to the other team about follow-up, right? So, I mean, the people at other hospitals, whether it be Mount St. Joseph's or Lionsgate or wherever. So either they're gonna make a phone call or they're gonna do it through there. And then if they make a phone call, we'll say, can you put it through, you know, because I mean, this is part of the patient's record. It should be, you know, in here,
Yeah.
So that report that Wayne was referring to, that is also a feature that we can build out through your message center, that the pools will get a notification when a patient's admitted somewhere else in a Cerner site.
Could we also add PD tube insertion here in case between our two sites? The nephrologist, a different nephrologist will have to insert a PD tube?
With that, do you currently do that right now?
We have done it quite often. Well, not quite often. We've done it in the past where we've sent our patients for PD tube insertions at St. Paul's. So it could happen the other way around also.
So in that scenario, we would want to have it as a separate order, not necessarily embedded into the follow-up order. And then you can select the scheduling location within that order.
Okay.
So yeah, Maritz, if you show them.
I think I have, sorry, I don't think I have the actual like PD insertion order, but then it would look something similar to this, where you could choose a scheduling location and we can include, like you could select St. Paul's here. Yeah. Okay. Right. Okay. So I think what I just wanted to just call out here is that with these specific appointment types, what we're suggesting is that we just to use the existing order in the system. So for a PD catheter removal, you would enter in the PD removal catheter tube order. Same with the PD catheter insertion. And like that scenario you mentioned, Dan, you can just select the appropriate location that could happen. The one thing I just wanted to point out is this HD catheter removal. My understanding of your clinic workflows is that this would be done through and booked through the VGH Renal Vascular Access Clinic. So we're just recommending that the scheduling location for this particular order would be VGH Renal VA. Does that make sense for your clinical workflows with how an HD catheter will be removed if needed?
I think in our process right now, we are the ones scheduling it. They just handed us the paper. We are the one who's scheduling the CVC removals, and then we give it back to them to inform the patient because we don't actually know the patients. Is that what we are doing right now, Dan?
We are. We're just getting a referral, but we're doing the scheduling, and we let them know when and which day, what times. So.
Yeah, so in the future, because we're building out the IDC procedure room as a shared resource, so Sophia will actually have access to that calendar to know when it's available, so she can actually do the direct scheduling.
But no,
But
she
the thing
can't.
is, just
No,
because
she
the
can't.
room's available doesn't mean the providers are available.
Yeah.
It's also dependent on whether or not we have fellows on that week and nursing staff as well.
Isn't she the one that arranges that?
Nope.
No, we are the one doing that.
So all the scheduling really is controlled by us here. We're just getting a referral, but well, we're kind of dictating where our spots of availability are. So
What I'm hearing is that we probably need to create a scheduling location for VGH peritoneal dialysis. And then for the vascular access clinic, they'll have their own scheduling location here for those scenarios that may happen in the vascular access clinic.
Well, I'm hearing it doesn't happen in the vascular access clinic, then it's Esther that's scheduling.
it happens in IDU in the PD clinic.
Okay.
So Esther, you're the one that books all the CVC removals and you just tell them the appointment, and then Sophia just contacts the patient?
No, not necessarily. Honestly, CST is a bit weird for us because our nurses book a lot of their own appointments. So for example, like Sophia will come in and she can actually go to one of the nurses and ask to see the schedule, what's the available time. Like it doesn't necessarily have to come through me. if anything, just because the nurses know their flows and they know, oh, like what pockets of time would be best, it usually makes more sense for them to book through the nurses anyways, because the nurses know how much time they need how much time that they need to allocate and things like that.
Okay, so can I just ask a question? So Sophia comes over and just asks a random nurse who's available, like how to look at the schedule, and then they choose who books this?
Yes,
And with who?
something like that, Pam. So Sophia will come in, and then she will ask if there is a CVC removal. So we're going to figure out if there's we're going to figure out if there's a fellow who will going to remove it. And then we're going to fit it in based on our schedule for the days that they want it to be removed. That is the first scenario. The second scenario is if it is our PD patient to transition to hemo, now we need to remove the CVC removal. We don't let Sophia know. We just book it ourselves because we have access to the schedule and to the fellow. And then we will let her know after we finish the CVC removal. So the process is not that concrete right now. So maybe revamping the process, or we can work out what we're doing right now.
Yeah, I think we need to work on this workflow because it doesn't sound.
Yeah, I think we should make it
super
unidirectional.
efficient.
Yeah, I mean, we should be a unidirectional workflow because right now seems to be bidirectional. Once we make it like everything would be coming from Sophia, and that would make sense, I believe. Not sure.
But the problem with coming from Sophia is she doesn't have access to the schedule of the doctors and our availability, because there's no definite time or like assigned time for CVC removals only. So it will be dependent on how much schedule we have on that day that they want the CVC to be removed.
Okay. So it sounds like there needs to be an understanding of what the workflow is so that we can build it out in the system to schedule appropriately.
Yeah.
Yes. Yeah.
Okay.
I agree.
So let's parking lot this and we can revisit it. Yeah.
Okay.
And then just very quickly, I know it's that time at 10. Dr. Singh, are you able to stay on for just a few more minutes? There's just a few more slides.
10 minutes at the most.
Okay, thank you. So just lastly on this kind of appointment types, there is this PD equilibrium test that's net new for that was requested for you guys. So we're suggesting potentially using the available scheduling related order in the power plan here, the dialysis equilibration full test power plan.
I'm confused by this. So there's a power plan for a peritoneal equilibration test. If that's the first test, then does this power plan also include like a 24-hour dialysis collection and all that? Does anybody know? I can't remember what this power plan looks like. Is it?
Let me just take a quick
because
look.
if it is, that one would be a completely different procedure with different instructions than just a PET on its own.
Okay, let me see if I can bring it up real quick here. Can you see the power plan?
No.
So this is the one.
Nope.
The screen hasn't changed.
Oh, the screen hasn't changed? Oh. It's okay. It just dragged over the power plan. No, okay. Let me just share again. Can you see it now? Yep. I'm just in power chart. Can you see this power plan? Okay, so this is the equilibrium one. I don't know it in like a lot of detail, but I believe you've mentioned something about 24-hour urine collection.
So I guess we can use this if we don't so sometimes when we do a PET, we don't include all of these, but the current tick boxes, they're always there and then you can do the other ones, or can we remove some of those tick boxes?
Yeah, you can deselect it. They're just defaulted to be pre-selected.
Okay, defaulted,
at this
right.
moment.
Sorry,
Yeah.
I forgot that. Couldn't think of
No
that
problem.
word default.
Yeah.
Okay, then we can use this. We just won't do the 24-hour collection at those times. Yeah.
Okay, so it is possible that we could do that. Okay.
So, sorry, Maria, I just, this is Esther. I just have a question regarding this. Like, for example, if they feel like they don't need a certain step of that, would I have to be the one who removes, like, untick boxes it
No,
before
Esther,
I
we do
book it in?
that.
Okay.
Providers do that.
Yeah,
Okay.
the providers would be the ones to do that. Yeah. Okay. And then we'll just have to have further discussion around the PD IV infusion appointment type and what order to link it to. But I think collectively what we wanted to ask the group was based on what St. Paul's has built out for them with certain appointment types being with a follow-up order and certain other appointment types being with the standalone procedure orders as individual orders and embedded in power plans. Would the build make sense for VGH? And it sounds like it does, unless there's any other questions about that.
So just one question. So the IV infusion thing that you were just talking about, it's my understanding, like at St. Paul's, it would happen in their short stay beds?
Yeah, that's right.
Okay, so all that would have to change is the location, right?
Mm-hmm. And then just the linking it to the appropriate appointment type. And Heather can get into that a little bit more in her future scheduling session.
Yeah, we would use those existing appointment types and I would just make them available so they can be scheduled at VGH PD unit.
Mm-hmm.
Just one last minute addition. I'm thinking that we at times bring in a patient just to teach them how to do Aranesp injections and so on. Is that part of our orders?
That would probably just be a nursing appointment, wouldn't it, Dan? Nursing teaching?
I believe it's in your follow-up appointment. It's right here.
Okay, got it. Good,
Yeah.
thanks.
No problem. Okay, I wanted to ask about case conferences because this came up in our enterprise overview session. So in Cerner, this is like booking a specific time and blocking it off. It's like a formal meeting of multidisciplinary team members. So I just wanted to confirm if the PD unit has like a formal meeting that needs to be booked and scheduled. Like there's billing that's associated with it. There's
we do. Yeah,
okay.
we do. Yeah.
Okay, so we would have to build. So what we can offer is we can build out an order. There currently is nothing for St. Paul's because doesn't sound like any of their clinics do any specific formal renal case conferences. So we can build out a new order and title it renal case conference. And then we just have to decide on case conference titles. And then if a case conference needs to be booked, this order can be entered in, and then the clerk can schedule and block the time appropriately.
So are you guys currently doing that where you have to place an order for Esther to book a case conference?
Well, but we have PD, like patient review rounds every week. So that is what I'm talking about.
Okay, so that's kind of different then. So if you're talking about the patient PD review rounds, then that's just, you guys have a set schedule every week that you know to do that. And it's not necessarily something that you need to put an order into the system for Esther to schedule it.
Okay, so can you clarify then? I obviously misunderstood. This would be like if we have a specific patient that we want to have a group discussion about, or?
Yes.
Yeah.
Okay, we do that then. Yeah, there are times when patients, like say, come in for the team to kind of assess like end of life issues, palliative care. Would that be?
Yes, that would then.
Okay, then we do that, yes.
Okay, so for those, you will still need an order then. If say you decided, oh, Mr. Smith, we want to bring Mr. Smith in to discuss end of life care, then you would place an order as a PD case conference, and then you would select the conference title as like end of life care. And then that's when it'll come up on Esther's list, and then she'll see it and she can book it accordingly. So for that kind of, appointment.
Can you?
Not the rounds.
Yeah, not the rounds, yeah. Can the group let me know what type of topics would normally be discussed at these case conferences? Then we could see if we can build out the appropriate options here in this drop down.
Okay, do you want them just quickly right now?
Or you can just
But I
email
gotta-
me.
Okay, good. I gotta get going. Thanks.
And Moritz, I just want to point out there is an option to keep the conference title somewhat generic and use the special instructions to get into more details if there's a
Great.
lot of options.
Okay.
There was saying less. Is there a thing like free write conference title?
I'm sorry, Chris, what was that?
Your appointment is not categorized to any of the drop down things, so you can just free write it. Is there something like that?
I
Yeah, the
believe so,
special
yes.
instructions is free text.
Yeah.
So the
Sorry,
special
this is-
instruction field.
But the conference title is a mandatory field, and that's what will link to the appropriate appointment type. So you do have to select something there, and that's why we can have a generic option if necessary for that.
Okay.
I noticed that Dr. Singh had to drop off, so we'll just have
Yes,
to, I just had a
she
couple of
can search.
questions. Yeah, that's okay. I have some questions that I can follow up with her on. So thank you for confirming this. We weren't really sure because sometimes there's confusion with like case conferences and clinics thinking that they're just booking like, you know, your post-clinic rounds and so forth. So thank you for clarifying that. I think I'll skip over the provider slide here. I just wanted to give Dr. Singh an update on a couple of power plants that came up. But I just wanted to confirm around medication. So we just wanted to know what your current workflow is with medications supplied by McDonald's Pharmacy, if they're delivered to patients directly or delivered to the unit. And let's say it's medications delivered to the patient directly. What happens if they forget to bring it to an appointment? What does the unit do then?
So for us, most of the medications are delivered to patient home, but not specifically McDonald's only. We are using different pharmacies aside from McDonald's. And then just in case it will deliver to the unit by accident, we will not receive the medication if this entails to be delivered to patient home. We will give it back to the courier.
Oh, okay. But when the patient comes to the unit and let's say they forgot to bring one of their meds, what does the nurse do then if they have to give a certain med support training?
We have our own pharmacy here. If that medication is available in our pharmacy, we will just take it there.
Do you submit an order or do you grab like ward stock supplies?
If it is available in the ward stock, yes. But if it needs to be, we will go to take it from the pharmacy. We need an order for that.
Do you guys have your own ward stock in IDC?
Yes, we do. And also, I cannot see any instance that we need a medication for the patient that the patient will not bring it and we're going to use it for whatever reason here in the unit.
Yeah, that was what I was going to mention. I can't think of any medication that we would need the patient to bring for the nurses to administer because it's kind of an outpatient basis.
Any for training though?
Ernest?
Yeah, for like injection training, don't they bring their own supply or you guys use ward stock supply?
So
Prevent is another one that we need to get pharmacists to do.
Okay, so we just wanted to confirm like that it sounds like your unit does have its own ward stock supply of meds. Like you wouldn't go to the hemodialysis area to grab any meds from their ward stock.
and that is partially correct because we have a hemo teaching here. So their fridge is accessible to us. So I cannot say that we need to go to the other place. We can actually steal it from their fridge.
Okay, so that does kind of happen from time to time. Okay.
And is there a workflow right now where you guys are checking the inventory of the stock?
For the PD, yes. For the home hemo, no.
Okay.
Okay, thank you. All right, so I'm just going to move to transition to a forms gap analysis. So I'm just going to let James present and talk through a couple forms.
Hello, this is James from the ambulatory team. So I just wanted to quickly review some of the gaps that we found between your paper forms and what we currently have built in the system. Let me know when you can see my screen.
You can see it.
Okay, so the CAPD form, it looks like we have most of the fields on your paper form except for this additional dialysate solution, the Neutroneal 1.1%. So as you can see in this system, we have all of the other solutions except the Neutroneal, so we could add those to these selections. I just wanted to confirm that you would need that option within all 4 dialysate solutions as well as the last dialysate solution.
Oh, Neutroneal is phased off already, I think. They're not, the Baxter is not, we're not using it anymore.
Oh, okay, great. So then everything we have in the system is up to date then.
We're just looking at the old form that never been revised.
Okay, thank you very much for that. And then the second form that I wanted to review is the current patient assessment. So we have this. Are you currently still using this training assessment form?
Yes.
Okay, perfect. So we do currently have an assessment form in the system. Although it only has one section currently, so we do not have a pre-teaching and a post-teaching section. So what we can propose is to, as you can see here, we kind of have one tab here. We could add 2 additional tabs, which would then show the pre-teaching in one tab, and then when you select the other tab, we could have a post-teaching section to go along with the initial assessment. And then as far as the activities, we do have quite an extensive list, but however, all of the selections within the red boxes we do not currently have in the system. So those would just be additional fields we can add here on the left. So the list would just be a little bit longer. And then another piece I wanted to point out is on your paper form, you kind of have this little legend here. But within the system, instead of a legend, we actually have those as columns. So you would just put a check mark within each column. Would that be appropriate?
Yes, if that process will work, then yes.
Okay, perfect. And then reviewing the bottom portion, which is the CAPD skills and objectives. We do currently have that captured also. So that piece is already, has everything that you have on your paper form here. So no changes to the CAPD skills. The last piece, I just wanted to get a better understanding of how this CAPD prescription portion is used on the paper form.
That one, when we finish training, we're gonna write there what the current prescription of the patient, and then if weight is more than something, so you need to we will change. They can change their solution to whatever we write in there. But on the right side, that is just a confirmation that you updated the promise. The PD adequate is the old adequate program. Maybe we don't need that, and you updated the cardex, and then you need to sign. You need to write the date when you accomplish it.
Okay. So regarding this, the prescription portion, would this be the provider or the nurse entering this?
It will be the nurses entering that.
The one portion that should probably be included in there, it's not just the weight, but it's also blood pressure. If the blood pressure is within this range, you use a solution. If it's below this range, you use another solution. So.
Okay, let me just write those notes down. So blood pressure along with the weight.
So can I just ask a question? It's Wayne here. The provider in the new system, because remember, this is what you're currently having, you need to think about how it's going to work in the new system. The provider will actually be putting the prescription in as a power plan. So it's actually stored in a different location under orders. So the question is do you actually truly need that?
The one you're showing on the paper on the bottom one?
Yeah.
No, actually. Yeah, because that is just a copy for the nurses. So it is just for our own copy. But if it is written on the other part of the Cerner, then we don't actually need that.
Yeah, that's what I just want to point out is a lot of this is potentially some duplicated spots. So think of it, yeah, that's the old way, but where can I find this in the new way? And that would actually be in the power plan that the physician would have made. And that's where you would go for your prescription for your patient. And in there, I can't remember if it has weight. It has everything in there. I'm not sure if it has blood pressure though, Maritza or anyone else.
I can quickly open it to see.
I actually just can't remember. So.
We used to do that a lot, especially for patients in long-term care like Holy Family. And we've always included that in there. So
it's there. I see it, right? There's the net fluid removal / goal weight section that Dr. Singh or any of the PD providers can select. And then there's the boxes there that you could enter in a value.
So the only one that I really don't see is really a goal blood pressure, like in the sense of, and maybe that's something to take back to the physicians is do they want like a blood pressure target or something along those lines? Or it could be written into the special instructions.
I would recommend the special instructions so that we're not modifying this form because it'll impact St. Paul's.
Yeah.
Yeah.
Okay, I think I have everything I need. Thank you very much.
Sorry.
Sorry.
Yeah. Go ahead,
Since you're on the line, we worked on a form together back for the Holy Family Project. And we specifically created one that included the blood pressure. It seems so important. In your Cerner process, I guess you guys removed it as one of the forms that you're using with long-term care?
On mute. Sorry, I'm on mute. Long-term care is now on Cerner, so they follow the same order sets and everything else.
Okay, so I'm pretty sure they probably have the blood pressure on there also. So.
Great, thank you. I'm just going to move over to VV. She just has a few other forms that she wants to review with the group.
Sorry, just give me 1 second so I can share my screen. Hi, everyone. So I'm Vivi. I'm on the acute care team at the CST project, and I'll be going through a few more nursing documentation and any additional changes that might be needed to what we call iView in the system. So the first one we're looking at here is the exit site classification worksheet. So I wanted to confirm whether or not this is used the same way as the BC renal form. I can open it up here. I think St. Paul's is currently using this form instead, but it looks like VGH has kind of like a modified, shortened version of this. But is the purpose the same?
Yeah, yes, it is. I think our form that we're using is actually a generic Baxter form before.
Yeah, I think this one's the Baxter form. Okay, so in that case, we'll be following the same workflow as PHC. So they currently access the form from BC Renal, or you can have a safe copy as well. Unfortunately, we're not able to build out the calculation required on the form. So that does have to stay on paper, but any documentation that you need to make to the PD catheter can be captured in the PD catheter section in the system. So I have a screenshot here as an example of some documentation that you might be doing for the PD catheter, but any calculations or anything like that that you need to use this worksheet for would have to be done on paper. Can I confirm though that that you mentioned that this is the old Baxter form, right? So is there a newer form that you're using now, or are you using the BC Renal form?
No, we like the old form. We're still using this one.
Okay, then you'll probably need this to be added to Form FAST then. I'll just have to confirm whether or not we can add a Baxter form. I don't know if anyone on the line is familiar with the HIM guidelines, but we'll just have to confirm whether or not this can be added.
So for when we cut over, we weren't allowed to import forms into Form FAST that we don't own. So like the BC Renal one. So our staff just go to BC Renal website and print them off. It's nice to be using the standardized provincial program forms as much as possible.
Yeah, I think you're right, Wayne, is that was the goal of BC Renal project, is to include, everybody uses the same forms. So yeah, that'll be a good way to go.
Yeah, and
might be time for a small change in practice.
Yeah.
If this is a form from Baxter, that's considered external site as well, and so Form FAST will not load it.
Good.
Okay, so then future state, you'll be doing the same thing as St. Paul's then. So you can access the form via the BC Renal website.
Just a little change.
It's a little change that adds up to a lot, and
it does
become a little bit overwhelming, guys. But once you get there, it'll be much easier.
Yeah, we're already counting how many changes. My pockets are full. Okay.
Don't. I would suggest not doing that.
All right, so no changes for exit site. So moving on to CCPD, this is the form that we had received. And I think this is the same form that PHC used to use. So I don't think any changes will be needed, but just a few things to note. Over time, some things have changed. So for example, ultrafiltration, there was a decision that was made to standardize the naming. So now it's called PD fluid gained and removed. So that information will be captured in these two fields here. There are also two hidden fields to document the 5th and the 6th solution. So you can always go into customize, and I think Maritza will show you this later, but you can go into customize and then pull up the 5th and 6th solution field if you ever do need to document it. I did want to confirm though, would you ever need to use more than 6 at a time?
No, but I just want to ask, what is this form? This is the nurse next door form?
This one is the CCPD log sheet. Is this not the correct one that you're using?
Oh, I think this is the CCPD log sheet for nurse next door.
It's a provincial form that not everyone used. Sorry, Vivian.
No worries. We had this one as well. So is this the one that you're using for all PD modalities?
No, this is a PD run sheet for inpatients.
Okay, so looks like we might be missing a form from you guys then. Would it be possible for you to send that over to us?
What form are we looking at? The CCPD form for the patient to fill up at home?
This is the nursing documentation. So do you need to document any like PD information, like log sheet information in the system? Or is it all done by the patient?
We are not using this form at all. We have a form that's similar to this that we are using when we are doing clinic appointments from the patients.
Okay, so I think that's the form that we'll need to have a look at then.
I think the difference is, and correct me if I'm wrong, VGH don't use cyclers when the patients are in hospital, do you?
We don't. Yeah, we just only do CAPD in inpatients.
So we use cyclers when the patients are an admitted patient within the hospital. So this is the new form that they're showing beside you, the continuous cycler PD form that's been built out. So when we run a cycler at St. Paul's.
So I think this form is not applicable to us then.
Okay, so sorry, so you guys don't document for CCPD at all?
Inpatient, we don't use cycler inpatiently, and the patient document their own results at home.
Okay,
How
so
about
it's
for
never done.
training? How about during training?
We're using a
Training.
patient's form that they're using for home. That's the form that we're using for them when they're going through training. Is that correct, Chris?
Yes, and also we just put the prescription on the cardex.
So when the patient comes for cycler training, you guys, the patient is just filling out the paper form that they use at home and there's no nursing documentation required.
We document this in the nurses or on the history sheet, and then the initial prescription will be noted on the cardex.
So we're just trying to find a place for when the patient is doing cycler training, when they're documenting on that paper form, instead of having it on that paper form, we want somewhere in Cerner where you guys can put that information in.
Understand what patient is documenting on the training.
The log sheets.
Give them a CCPD log sheet to bring home.
Is that something that the nurse would need to document? Is this only ever documented by the patient, both at home and in hospital?
So this one is not applicable too much to us because most of our patients is on AMIA, and the average dwell time, added lost time, total EF idling volume will be visible on the share source.
Yeah, so, and I just checked with Jen, when we're doing training, we don't use the continuous cyclopedia form. They just put a little narrative note of what they did with the training piece of it because it's available through AMIA as well. So, because ultimately they're not getting a full cycler potential run during their training anyway. It's really just teaching.
Okay, so it sounds like you guys don't even need to document in CCPD at all. So it will be available in the ban, but you just won't use it. Okay, so moving on to this one, I think you said that this also wasn't the correct form. Is that right? It is used by inpatients though, right? But what about the clinic? Are you using a different form?
We have the, yes, we are using a different form to record that. This is I think this is a non-official form that we just created so that when the doctor will do the rounds, they can easily have a summary on what's happening to the patient in terms of PD.
Okay, so because I don't have the form that you're using, it's difficult for me to identify any gaps that we have, but I do have a screenshot here of what we have built out in the system for CAPD and manual IPD. I don't know if it's worth it for us to review now, or if it's possible for you to send us the actual forms that you're using, and maybe we can go over that in more detail at the next session.
Sure.
Hi, Chris. My name is Irvin. I am working with VP. I was just wondering if I understand correctly, you are using this form for the unofficial form for the physicians to see a trend of the different values in this form over time?
Correct.
Okay.
But this is not a official form. We just created it.
Okay, and so and then the other form that you mentioned that you are using is also used the same way in terms of trending?
It's the same, but it's quite a different format.
Oh, okay, but same purpose.
So it's kind of redundant, actually.
Okay, thanks.
Okay, well, I don't know if we have any inpatient reps here, but I did have a look at this form, and everything captured here is in the system. So they can definitely continue trending it once you guys.
So the form that we use for the nurses use to document inpatients dialysis runs is actually the same as the one that we use for when the patients come for 3 times a week IPD at the beginning of their training.
Okay, so is this form just not used at all? Or is this more of like a high level view of these specific columns? Like, so for trending purposes only, but you're also using the same form as the clinic.
Like, are you talking about the form that you have on screen right now? Because
Yeah.
like Chris said earlier, that this is kept on the ward.
Okay.
So whatever doctor rounds on the patient, they can see the trend of the exchanges that have been done over time.
Yeah.
But this isn't an official form. The official form that we're talking about is actually one that we actually have to send to health records.
And that's the same form that's used in the clinic, correct?
That's the same form that's used for IPD.
Okay, so sounds like it might be another form that we'll need. So can you also send a copy to us as well, so we can do the gap analysis, and then we'll bring it back at the next session so that we can review any gaps if identified.
Okay.
Thank you.
Hi, this is Jenny from Tower 11H. I just want to chime in. I also don't use the form on the screen. We're using the continuous ambulatory peritoneal dialysis run sheet. So I think having that actual form would be good to identify gaps.
Okay, great. Once I receive those forms, we'll do the gap analysis, and then we'll bring this back for discussion at the next session. Okay, so we'll skip over the log sheet for today. This was the other form that we found. Is this one currently being used, the PD program patient assessment?
Yes, so this is the form that we are using when we do clinic.
Okay, and can you tell me how often it's filled out during the visit?
It's every visit.
So once every visit?
Clinic visit.
Okay. So I had a look, and a lot of this information is currently captured somewhere in the system. It's in what we call the adult systems assessment band, which is normally used in the inpatient space, but it sounds like this is just something like you do this at every visit with the patient, but it's only done once per visit.
Yes, it is. Yeah.
Okay. I'm not sure if this might be more appropriate in a power form, and I'm looking at the project team right now, to be captured in a power form, or if we want to continue leveraging the systems assessment band.
Is it easier for us to navigate and try to figure out where to input it every time we do the clinic?
It is kind of scattered everywhere. So I can show you what the systems assessment band looks like. So for PD, most of the information that you'll need will be captured in the dialysis management band, but for the systems assessment information, it'll be under adult systems assessment. And this is a band that's used enterprise-wide. So it's shared with a lot of different areas. So there's a lot of information in here, but just because it's here doesn't mean you have to document on it. So you do have to kind of leaf through these sections to find what you need. So you'll see that I've indicated edema, documented under edema assessment. It's all, the information is kind of scattered everywhere.
Just skip the form?
We could keep the form, but
Don't make it harder on us. We've got too much to learn already.
So Chris, can I ask, or whoever, how often per visit do you have to document the patient assessment?
It's once every visit. So patient more or less will have, for well patient, it will be like 4 times a year. Some of the patient, it will be like once a month. So
okay, so it's very infrequent. With these bands, it's common across different sites and inpatient or all throughout departments to be navigating in between bands, because a lot of departments use this adult systems assessment, and then they would go over to, for example, intake and output up there, or maybe even adult lines as well, because for lines, they always have to go to a different band. So if you chart it very infrequently, I think having it on the system and charting in just iView is very beneficial to look at it over time electronically.
We might have different views on what's infrequently. Ours is not regularly, is called infrequent. And so your version here would infrequent means that every blue moon. And to have to navigate through different windows just to get the information in, probably not doable
Yeah,
for us.
I definitely agree with that. With iView, it's really mainly used in the inpatient space because it's kind of like documenting on a flow sheet. So it's done at very regular intervals, but because you guys won't be documenting it very often, I actually would recommend having this captured in a power form instead. So every time you need to do the assessment, you just bring up the power form. Obviously, we don't have it built out, but there's this ad hoc button up here where whenever you need to document it, you just go into your form and then you can open it to chart. So I think that would be better than to document in this adult systems assessment band, because it will be very difficult for you to navigate. And because it's done so infrequently, you'll have to look for all this information every time. So I think
Absolutely, I think you're right. And that way we don't miss information either if we have to navigate through so many windows. So you're right.
The power form we owned by the ambulatory team on the project. So I'll work with them to transition this over, but we'll try as much as possible to leverage the existing fields that we have so that the information transfers over. So like when the patient's in the clinic and they get transferred to an inpatient unit or something like that, it does transfer over so that inpatient nurses can still view the same information and document in the same fields. Okay, and so the next thing I wanted to ask, I did take an extract because I did hear that it's possible for patients to be on both HD and PD at the same time at VGH. Is that correct?
Yes.
Okay, so currently, sorry, this is the extract of the dialysis management band, so it might not make any sense to you at the moment, but I just did a check for any duplicate or shared fields that we have. So the idea behind the design before was that we were told HD and PD would never happen at the same time. So there are some fields that are shared. Well, there's actually just one. So there's one field that's shared between HD and PD, which is the dialysis goal weight. So what that means is when I document under goal weight here for CAPD, I'm just gonna enter the number, and then I save it, it actually pulls it into the HD section as well. So HD also captures goal weight. So you'll see that 50 is here, which I think is not appropriate, right? They could have different goal weights. Is that correct?
Yes, you're right.
Okay, so we'll have to create a new field that's unique to PD so that it's not shared and the information doesn't cross over. Can I also confirm if patients can be on different PD modalities at the same time?
Yes, there are patients that do 5 days a week of PD and one-time hemo.
What about different PD modalities? Like, can they be on?
Yes, there are people who
CAPD,
change from
at the same
CAPD to
time?
CCPD. And I think that is not a restriction for them to do, so they can do it anytime.
Okay,
and to follow up on that, does the provider need to write a new prescription for the changes in the PD modality?
Not necessarily, but yes, for documentation. But in terms of the solutions and all the stuff, it will just copy the same way when they are cycler or CAPD.
Okay, so then the goal weight then can be the same. So if you document under CAPD, goal weight is 50, it's the same if the patient was on CCPD. Is that correct? Okay, perfect. So PD can still share the same goal weight field, but it cannot share with HD. Okay. I don't know if Wayne is still on from PHC.
He messaged me and said that he was dropping off to attend rounds and would be right back. So I don't know if he's there. He might not be.
Or anyone from PHC. This is going to be more a problem, or not a change for PHC, because currently they are using the same field as HD, and it's not a problem for them at the site. But if we're going to be changing it, it will affect all live sites that are currently documenting in the dialysis management plan. So maybe I can go through this again once we know Wayne is back, because this doesn't really matter for VGH. Okay, that was everything from me. Once I receive those paper logs that you guys are using, we'll bring it back and discuss again at the next session. But otherwise, I will pass this back to you, Maritza. And then when we know Wayne is back, if we can just loop back to the goal weight conversation, that would be great.
Okay, sounds good. Just wanting to check in with the group. Are we okay to power through, or do we need like a 5-minute break to go to the bathroom, get a drink of water? Power through?
Yeah, I'm good to power through, but
Okay.
no objection, anybody? No? Good.
Okay, sounds good. We're just going to move into reviewing some nursing functionality. So I'm just going to pass it over to Dennis.
Hi, everyone. My name is Dennis. I'm one of the CIS here, St. Paul's. I'm just going to share my screen. Can everyone see my screen okay?
Yep, I can.
Yeah, sure. So thanks. So I'm going to show the workflow of an ambulatory nurse and also go through the differences between the ambulatory and versus inpatient. So this first scenario is for ambulatory nurse who is checking in the patient through the system. So the landing page automatically will bring you to this page here, the ambulatory organizer. And what you find here, you find the resource where the patient has been booked. I think what we were talking earlier, the resource and the patient name and what the reason why the patient came in. So I'll just click here and go in to see. And this opens up the patient chart. I wonder, can you see the patient chart?
Yes.
Okay, sure, great. Okay, just to point out a few things here. First of all, I'm gonna go through the dialysis prescription. Once you open the patient chart, you'll find the prescription right away on the ambulatory workflow. So you click on the ambulatory workflow and the dialysis prescription will be here. So that would be your first go-to place. And just to recap also, there's also the blue banner here, the blue banner. It has the patient information, and also it points out where the location is. And I think we were discussing earlier, if you want it to be VGH, PD unit, so it's gonna show up here. And then counter is gonna show if it's recurring. Whereas in inpatient, you'll find that there's a difference on how the encounter presents itself there. And also there's the toolbar here that helps you to like navigate through Sana with the various tools there. So as soon as once you see the prescription, automatically you're like, where do I see the orders through the system? So you'll go onto the orders here, and your nephrologist will have placed the orders already into the system. So as soon as you'll be reviewing the order. So in this case, I'm going to talk through the peritoneal dialysis training treatment order. So you'll be, you can click here and you review the orders. So this will be just checking if the orders are correct. And another window will open up, there it is. And you can say, I've reviewed the orders and you're good to go. So there are some certain modalities here we have to walk through. Is when you review the orders, you have to make sure that you activate these orders because they've been placed in a future state. You have to make sure that when you activate the orders for these patients, that it's for the right time and the right date. So I'm going to activate these orders that were placed by the nephrologist. There you go. So you can see that for this day one training, when the patient arrives, when you activate these orders, it changes from future to actually the activated orders. I'm going to sign this up and
Sorry, can I just make a quick comment there, Dennis?
yes.
So for you guys as nurses, these are day of treatment power plans. So they're built out where there's different days to correspond with the training specific time. So there's 5 columns. So the one thing just to note is you need to ensure that the date that the patient arrives for their first day of training is appropriate. So from that kind of drop down arrow that Dennis was showing, there is an option to change the date and time to be reflective of the current date. So just make sure that when you do activate the power plan, it is reflective of the date, and you would need to modify the date to ensure that it's correct.
Yeah. Thanks, Maritza. And this is how you'll do it. So just if you're working through this, since I've activated, I can't change the date. But in the future, if you want to do, you can come here and like change the date here if you want to do that, and make sure that if it's today you're working through the 16th, you can like choose the date there 16th and click OK. I'm going to cancel because I already initiated the one for 16th here. So once you activate the orders, so these orders are going to flow into your MAR for the nurse to execute. So in this case, I'm just going to refresh last given on this. So you'll find that we have a topical antibiotic that has been pulled from the power plan, and here on the 16th, it's where, let's see the application given. Yeah, so so here you can see that on the 16th, this medication has not been given. And also we have ciprofloxacin, but this one has not been activated yet. So we're gonna work with this topical antibiotic. So to do that, there's a tool on the toolbar here. It's called the medication administration. So this is where we call the closed loop medication administration system, where you're going to scan the patient and you're going to review the medication before you're going to scan the medication, and also going to scan the patient before you give out the medication. So you can find that once you scan the patient, then this medication that is due here on the 16th, which is the topical antibiotic, you're going to give it and you're going to sign it after you've done everything. And it shows here that it's complete. The task is complete. I'm just going to refresh. And yeah, so you can see that if you hover over it, it says one application authorized. So if you move to the MAR summary, it's going to refresh it again. So you can find that the MAR summary gives you a chronological way of viewing the orders that have been done into the system. And here, the topical antibiotic has already been given. So it just kind of gives you it just shows you how, what your documentation has been done for your medication, similarly to your paper MAR. So the other thing that nurses will be doing into the system will be documenting. And I think Vivi went through the initial part a little bit, and I'm just gonna power through these. You're going to click on the interactive view input and output. So with these, there's a major difference between when you're an ambulatory nurse versus an inpatient nurse. So with an outpatient nurse, in this case, this has already been built in, but for inpatient nurse, you have to pull into this navigator band because essentially it hasn't been built for those kind of nurses in the unit. So I'm going to show you through how you document, and I think from what I understood, you're not doing the cycler. So I'm going to try with the continuous ambulatory PD. So then when you click on these sections, the flow sheet comes on the right here. And the best way to activate that, you just double click that, and you can say, you can power through that and click there. You can choose the type of solution you're using for the client. You can say the flow still volume, maybe 100. PD fluid gain, maybe 20. So you can continue with that as you go through that. And then, yeah, and once you're done, you come and check off the sign here to make sure that that information can be accessed through the results review. We'll check that, and that the information is saved now into the system. And I'll also show you how to document through the peritoneal dialysis catheter. So in this case, I'm going to introduce to you something called the conditional logic order. So in this case, when you click onto, sorry. So yeah.
Sorry, just wanted to just add that for any kind of tubes, lines, drains like CVC, PIVs, et cetera. So in the system, we need to create groups for them so we can document our assessments and the care that we provide per line, tube, and drain. So in this case, we have to create a dynamic group for your PD catheter. So you would just kind of click that little like Rubik's Cube. It looks like a little square. And then you create like a net new group depending on the number of lines, tubes, and drains the patient has, and then you can kind of document through. Sorry, just wanted to point that out, Dennis.
Yeah, thanks, Marisa. So this is the dynamic group. So you can document what kind of catheter you're using for this client, and you click that. Then you can also check off that just to make sure the information is pulled through. Let's say if you want to document on this site of the condition, you can just continue power through that as needed and save it there. So once you're done with your documentation for this client, all the documentation will be visible through the results review. So I'm going to refresh that. And if you come to dialysis view, you'll find that all what you've documented, like for the 16th, you can find it here. So we just documented maybe on the site condition, it was the erythema, and it can be pulled out here. Let's see. So the best thing about results review is it shows you all the documentation in a chronological order. So you can kind of follow through from the earlier dates that you documented on this patient as you go through that. And this is where most of your physician will be seeing what you've done for the patient. And also with this results review, you're able to see the order, the peritoneal dialysis prescription that was inserted earlier. Similarly, with the results review, you're able to look at other stuff like labs and all that in a chronological order too. Then I'll come into documentation. I think Vivi actually mentioned earlier, with documentation, when you want to document maybe the training for these patients, so you can come here into the ad hoc button and click there, and you can try the patient checklist and open that up. So I already chatted, so you can take over where the nurse had already chatted earlier before, and you can continue with the chatting. So in this case, maybe you can say you've taught the patient about showering and how to view their laboratory results. So you find these X checks here. Then you click the tick, then it pulls the results into the documentation from the ad hoc power form into the documentation. So the best thing about this is you can view it in either the, if you double click here, it brings the form, and you can continue to document from the documentation side, or you can also look it up here in a textual rendition. So it kind of brings up all the information in the form to a narrative way for you to see that. So then the other thing I want to show the nurses is how to access the same form on the form browser. So the form browser also gives you, so for today, we're looking at peritoneal dialysis checklist. So if you click on that, the form browser, you're also able to access this form just at a glance, but I don't think you can actually, good thing is you can actually, you can't edit from here, but you can edit it from the documentation side. So I think that's it for mostly for the outpatient. And I'm also going to show you how the inpatient workflow will look like. And just bear with me. Great. I'll put on my screen here. So when you have an inpatient scenario, this will be your landing page. And this is where you will see your patient, for instance. With the inpatient, it's easy to find all the orders that were placed into the system just at a glance over here, and see the patient information just briefly over here too. And you're also able to see which tasks they are overdue. For instance, for here, you can see you haven't done the weight check, or it's overdue, you need to do that, and what tasks you need to do next. So I'll click onto this patient. And
just before you go, Dennis, just want to point out that the Care Compass is an application that's mainly for inpatient nurses. So Jenny, these are for your nurses. They will open up Care Compass, and that is their landing page, and that's where they can review upcoming tasks, overdue tasks, as well as review any net new orders or results. So I'm not sure if you can go back to Care Compass, Dennis.
Yes,
just wanted to call out that like there is that kind of orange starburst around the patient's name. So if you were just to click into the starburst, yeah, perfect. This opens up or brings up another window that allows you to see any net new orders placed on the patient. So this is different than what your PD nurses would use to review net new orders. So just want to call out that difference here.
Yeah, thanks, Marita.
Thank you.
Yeah. Yeah, so I'm just going to highlight one of the a few differences between the inpatient and outpatient. So for instance, here, if you look at the blue banner, you can find that the encounter type is inpatient. So with this encounter, you'll be able to know, oh, my patient, the patient I'm dealing with, actually it's an inpatient one. It actually shows you the location also too. But the rest of the information will remain the same. And from the other side, you find that we're looking at the ambulatory workflow, and with the inpatient, the name just changes to patient summary. So the main difference between the other outpatient and inpatient is you cannot find the dialysis prescription over here, but you can find it through documentation and form browser. So I'll just show you how it's done. So let's say this is the prescription that the nephrologist added earlier. So you can find the prescription over here, but you cannot see it through the patient summary workflow there. So then, sorry, I'm just gonna cancel, yes. Then the rest of the stuff will remain the same. How you access your orders will still remain the same. How you check your MAR will still remain the same, and your MAR summary and iView. So with iView, there's one major difference between the outpatient and inpatient is the dialysis management band is not built in here. You have to pull it through here. So for you to pull it, you click on the interactive iView and go to the view section and layout. It's going to take a lot of practice here, but yeah, just bear with me. So layout and navigator band, and this is where you will pull through your dialysis management and you click OK. And when you do that, then it will be added onto the system for you to continue to chat. But the charting still remains the same. Or if you go click on continuous ambulatory PD, you can still chart the same way. And the results from here will also be pulled into the results review.
Sorry, Dennis, can I just ask a quick question to Jenny?
Yeah.
So I can't speak for the ambulatory physician, but for inpatient nurses, Jenny, we can do location flexing for the bands. So currently for the nurse position, the dialysis management band is not defaulted to display. So like what Dennis was showing you earlier, you would have to manually pull it in for the patient. But if this is something that's used frequently at, I think it's T11, we can make it so that it does display for any patients that are in T11. Is this something that you think would be useful?
So for Tower 11, we get safe patients that need PD like periodically. I feel like if it's built in, if we don't need it, we just don't have to click into it, right? So I think if it's built in place, it would be more helpful for the nursing staff.
Yeah,
yeah.
You can definitely take this back and let us know if this is something that you're interested in. Otherwise, it just won't be defaulted and you'll have to manually pull it in. And then if you do decide to have it manually pulled in, it will be visible. But I mean, if it's not, if the patient's not on PD, then you just don't click on it and you don't document on it.
Dennis, maybe you could show.
I think that makes sense. Yeah. Okay.
So Evan, you had a question?
Yeah, I just want to mention maybe it helps if you show how to pull in and remove navigator bands.
Oh, okay, I was just taking them through that. Thank you. I'll do that. So if you want to pull the navigator band, you go to the interactive view and you click on that. Then you go to the view section and come to the layout. And this is the navigator band. So with that, it brings this window over here. So let's say if you want to pull something that is not there already. In this case, let me just do this.
So you'll have to pull from the column, the box on the left, find the specific band that you want, and then
to the right. Yeah, I'm just taking the dialysis away, then I'll put it back in so that they see how it's done. Yeah. So in this case, I've taken away the dialysis band. Let me see. It's gonna show up.
You have to exit out of the patient's chart and open it again.
Oh,
and close the patient's chart.
Yeah.
Oh. I think you close the entire power chart.
Yeah, just give me a second. I'm going to open it up.
So while Dennis is doing that, Jenny, I probably recommend just having it location flexed. Just it's easier. It's just kind of there in your eye view with all the other bands. And then when there is a patient that requires PD, then the nurses can just select that band and then it's there. They don't have to pull it in each time. Might just save some
I think that's a great idea,
sometimes.
especially, it might like impact a lot of nurses. So I think having that built in for the patients that need PD. Thank you. I agree with that idea.
Yeah. It's just that the dialysis management is a specific band for renal, and because your nurses on your T11 would just be using a generic nursing position, it's just not built in for them. So
yeah, so just to thanks Maritza for that. So in this case here, because I've taken it out, you cannot find it here for the dialysis management. So you have to also go through iView and pull it back, pull the dialysis management back in. So you go through the same procedure and look for the dialysis management. It should be up there. Let me know if you see it too.
It's in alphabetical order, so
yeah. So. Great. And you have to exit again, and it will show up here. I think those are the major differences that I wanted to highlight. And just before I leave this session, for this nursing session, I also want to mention that there's also the SunQuest Collect. Similarly to how you will collect, you'll administer medication and go scan the patient and the medication. That's how also the system will prompt you up when you have orders for like collecting lab orders. You will open this application here, and it will help you to scan the printer, to scan the printer to to match it with the patient's file. And in this case, you're able to get some labels for this patient so that you can use it to label your to label your specimen when you're taking them to the lab.
Hey, Dennis, why don't I just share that PowerPoint slide and then you can talk through that workflow.
Yeah, okay? Sure. Yeah, you can bring it up.
Okay.
Thanks, Maritza.
No problem. So can you guys see my PowerPoint again?
Yeah.
Okay, perfect. So this is the clinical collect workflow. So I'll let you talk through it, Dennis. We just can't demo because it's a mobile printer and then we don't have a workstation to scan. So
yeah. So basically, you turn on the printer, and when you turn on the printer, you open the patient chart as we had opened for Page. So then you open the Sunquest collect button that I showed you on the system there, and you pair the printer to the patient's chart, and you scan the patient to make sure everything is in synchrony. And when after that you collect the specimen, then you'll have the printout, the print labels ready, specific to that patient and to the labs that were ordered for that particular visit. And you can send the specimen to the lab with the correct labels on them. Yeah, so I think that's where I will stop. If you have any more questions, I welcome to answer any.
Any questions for Dennis? So Jenny, hopefully that kind of gives you a better idea of how your nurses on your unit would be able to support PD patients that come through.
Yeah, it helps a lot. Thank you.
Awesome.
Yeah, thanks. Okay, thanks. I'll give it back to Maritza to continue with the rest of the PowerPoint.
Thanks. Vivi just had a good question. I see that Wayne's back. We were just talking through goal weight, that line item in iView, Wayne. So there is a need to potentially build out a net new goal weight for documentation, because PD and HD can happen at VGH concurrently. So the way it's designed right now, if we were to document goal weight in one of the PD specific sections in iView, it'll pull into the HD section, which is going to be a little bit of a problem.
Trying to find my unmute. I think this has been a big problem even with us over here, is where general like goal weights, med weights and stuff overrid the HD pieces. So I think you might want to dig into that one a little bit, Maritza, because I think this issue has been brought up before.
Okay.
Because it's the same over here.
Yeah, sorry, this is Bibi. It did come up for St. Paul's with HD before, and so we did make that fix. But at the time when it was fixed, I didn't realize that cutover was required, because I think the providers were using the goal weight value to determine patient care. And so when the change went in, it like wiped all the information. So if providers were looking for the goal weight, it wasn't there anymore. So we're just trying to determine whether or not something like that would be required at St. Paul's when this goes through for VGH. It won't really be an issue for VGH because right now they're not on the system, but for anyone currently on the system, when we separate PD and HD goal weights, the PD weights will get wiped, and then the information won't be available for providers or nurses or anyone looking at the information to refer to. So I just wanted to confirm whether or not we need to look into having cutover so that the nurses can redocument the goal weight when this goes live.
So isn't it the actual power plan where the goal weight's recorded and that's a physician entered thing? So wouldn't that be a physician cutover piece? And you can tell them, not me.
I believe that field is not shared with the nursing documentation. So the one in the power form prescription is different from the one that nurses document in iView. So if the providers aren't looking at the nursing documentation at all, and it doesn't matter if the nursing goal weight is wiped, then we don't need to do cutover. But if that information is needed by someone, then we would need to look into doing cutover for at least the active patients that are still coming in.
And this is for the inpatient or the outpatient side?
Both. So
Okay.
any patients that will need, or any areas, any nurses, any people who will need to see the goal weight documented by the nurses for PD will need to do some kind of cutover if the information is still required. Otherwise, when the change goes through, you won't be able to find it anymore.
Oh, well, they'd be able to find it in the orders. That's where I'm slightly getting confused, because ultimately I think the goal weight is in the order. So why are we having to record it in two separate spots, and why doesn't it pull through?
From my understanding, the one in the prescription is the one that's actually prescribed by the provider. The one in the log sheet, which is captured in iView, is what the nurses actually document at the time of treatment. So the values could be different. Now, if this is actually a transcription, so the nurse is just taking whatever the provider had documented and then entering it into iView, and it's the exact same value and it's always going to be the same, then we definitely need to look at the design and potentially remove the value, because they shouldn't be transcribing.
Yeah, no, that's actually my question, is because ultimately the goal weight should be set by the physician, and that's what we should be going through, not what the nurse determines as the goal weight. So I think this needs a little bit more investigation, and I'm going to go talk to some of the staff around here.
Okay, sounds good. Thanks, Wayne. Well, I'll try to dig on some more information on this side as well.
Okay.
Thank you. Okay, I just wanted to talk through about COVID screening. There is an available Power Form to document symptoms and do the patient screening. It is found through the ad hoc folder that we've kind of seen discussed a few times already in this session. So the nice thing about the data, if it's like when you do complete this form, it flows into the iView, there is a COVID specific section and it is visible in results review. I'd like to know what the clinic is currently doing and who is doing the assessment when the patient arrives, or is that what you guys do? Let me know how you guys do COVID-19 screening.
So for us, the nurses do the screening all the time.
So this is for initial and follow-up appointments?
Everybody who will enter the room will get screened, no matter what the appointment is.
Okay, so and you guys are currently using a paper form to do this right now?
The BCPRA paper form, like it is actually the hemodialysis screening tool.
Okay, so we would recommend to have to use the Cerner COVID-19 screening form, just because the data when the form is completed is visible for other clinicians when viewing the patient's chart. So you don't really necessarily have to use your paper form. Okay, so if the nurse is the one doing the screening when the patient arrives, they'll just have to bring it up and complete the form before you follow through with your appointment. Sorry, Chris, I don't know if you got that.
Okay, I'm interrupted. Say that again.
Yeah, sorry. So if you're telling me that the nurses are currently completing the screening, we make the recommendation that you use the Power Form that we have available in Cerner to do the screening. So you would have to open it up, complete the screening before you conduct your appointment with your patient.
So we're doing it outside. So how do we do it?
You could have a workstation on wheels that you could bring to meet the patient. Another recommendation that we've made in other sessions is that we recommend that the clerk can do it at the time of patient check-in. And then that way you're not having to bring the patient into an exam room to do the screening and then run the risk of the patient being symptomatic. So I'm not sure if that could be something that you guys could adopt as a new workflow.
Yeah, the unit
So
clerk
that
is the only person, There's only one going to clerk. And, you know,
Yeah.
with this Cerner, she had like 10 million things to do when checking in patients.
So this is a workflow change that we just had to implement because of COVID-19. It's just something that had to happen where we either have a nurse up the front that does it or our clerks do it. But it sort of has to happen. So quite often, if we're just putting the patient into the room, the patient may just go in and go straight into the room and then be arrived in, and then the nurse does it. It all depends on the area.
Understand that what is there like a printed paper form on this one, and then we can input it later, but or it should
It
be
can be
like
done
real
straight
time.
in. It goes straight into the system.
Yeah, so when you complete the power form, what you see here, it's visible in real time for any other clinician looking in the patient's chart. So we do recommend to use the power form so that that information is available in real time, rather than filling in a paper form and then scanning it back into the chart and having it live within the documentation list. It kind of gets lost there.
And the nice thing about this one is it actually allows you to screen the visitors as well, because there's actually a spot for if they had a person coming in with them.
We're screening it, everybody that's going in, but yeah. So if we have the technology and the infrastructure to do it, yeah, we'll surely do it.
Okay. So yeah, so then our recommendation is for you guys to try to use this form, and then from an operations perspective, if it's still the nurse doing it, have some sort of like workstation available prior to bringing the patient to an exam room, or exploring whether the clerk can do it at the time the patient check-in. Okay. Okay, I'm just going to move on to allied health specific stuff. I was just curious to know if there are any more questions from a nursing perspective before I move on.
We're okay.
Okay. So I think, Kevin, are you still on the call? Good. I just wanted to call out that as a pharmacist in the system, you do have your own workflow, and you can access the dialysis prescription section from that workflow. So you could use that to support any of the work that you are doing. In a previous session, there was questions that came up about where to document drug coverage. So there is a patient preferred power form that you can access within this workflow. And then you could document special drug coverage in this box here.
Oh, great. Thank you.
No problem. And then from a social worker perspective, Joanna was kind enough to send us her current template. So I just have that listed here on the right-hand side, and just reviewing what we have available in the system. We do have the enterprise psychosocial assessment power form. So just doing a quick crosswalk, most of what you currently use and document to in your paper template should be accessible in this psychosocial assessment power form here. So let me see if I can go into the system and just quickly show you what that looks like, if that will help. Sorry, my apologies. I just have to quickly log on as a social worker. So this power form is accessible to you through your ad hoc folder. And sorry guys, just bear with me. I thought I had the social worker login already available for me.
Hi, Maritza. I am here. Is there anything I need to do here? Or you're just trying to pull it up?
I'm just trying to pull it up.
Okay, okay, great. Yeah.
Yeah, can you guys see my power chart?
I can see the psychosocial assessment power form.
Okay, I'm just gonna have to stop my share and just reshare. Sorry, guys. Okay, you see power chart? I just have a patient chart up. Can you guys see that okay?
Mm-hmm.
Okay, so I'm logged in as a social worker. So there is the ad hoc power folder here through the toolbar. So there is, and this is built out for most of all the allied health professions, their own specific folder. So for a social worker, if you click on your specific folder, there's a number of different power forms that is available for you. So specifically for psychosocial assessment, it's here. You can click onto that and it just brings that up. So all the sections that you need to do a psychosocial assessment would be available. So you just kind of click through the different sections and then be able to chart your assessment. And then once that assessment's completed, you can find your documented assessment through the documentation. I know Dennis kind of walked through that a little bit with some of the nursing stuff, but all of the power forms, when they are documented and completed, are visible and can be found through the documentation list here, as well as through Form Browser. The one thing I just wanted to point out, and this is applicable for all clinicians, is that within your workflow tab, and then going through the different components here, there is a patient information component. And this is where there will be a lot of pertinent information that will be face up and visible. So for example, TSDM substitute decision maker information will be visible here. There's a number of different tabs across the top. So just tying back to the patient preferred information power form that I spoke to about with the pharmacist, that information will be visible face up here in this section if you click on that tab. And then to find that specific form, there's a little caret here that you would select, and then you'd be able to bring that up. So for social workers, if you need to do any TSDM, SDM documentation, you can bring up that form and document to that as needed. Okay. And then just to note, there are a number of different note types that are specific for your allied health profession. So for a social worker, there's a social work note type. So if I were to click into that hyperlink, it brings me to the documentation, and I can just free text anything I need from a social worker's perspective. There's also this outpatient visit summary that is available for all of the allied health professions. So you can document through this as needed, and then sign and submit, and it'd be visible through the documentation tab when that's completed. I'm gonna stop sharing, go back to my PowerPoint slide deck. Sorry for like flipping back and forth, everyone. Okay. Can you guys see my PowerPoint slide? Just want to make sure.
Yes.
Okay, perfect, thank you. So that was the social worker portion that I just wanted to call out. For any OTs, again, through the ad hoc application in the toolbar, the occupational therapist does have a number of power forms specific to their work. So you just have to find the occupational therapy folder. And then for the purposes of the PD clinic, there is the outpatient reassessment and outpatient initial assessment power form that you can pull up to use. There's also specific dynamic document note types for the occupational therapist. And then the other thing I just wanted to showcase for you guys is the multi-patient task list. So all allied health clinicians will have this available to them, and they should be able to manage their caseload. So this is what the multi-patient task list would look like. Depending on your allied health profession, there are a number of different tabs for you across here. I am logged in as an OT right now, so that's why it's the OT specific ones. So how you would manage your caseload is based off of consult orders that other clinicians or providers can enter in the system to consult you to follow up with your patient. So when that order is entered in the system, it triggers a task, and the patient would fall into your multi-patient task list for you to manage your caseload. When you are finished seeing the patient, you can complete that consult, and then the patient would drop off from your list. If the patient needs to be followed up, in the future for whatever reason, then you would have to enter a following order to have that patient remain on your list. So I'll just quickly go into this patient's chart to show you how to do that to enter in the following order. From here, I'm just gonna click add, and then the orders catalog will be available. So the following orders are only intended to be used by the allied health profession. So I'm just gonna select the following order for the OT. And then from here, I can enter in as a free text box the reason for follow-up. So I can enter anything here and then sign for that. And then navigating back to my multi-patient task list, and refreshing, the patient should still be on my list for me to follow. Any questions there? That the multi-patient task list is enterprise for all allied health professionals, so you'll be utilizing the same workflow to manage your caseload.
Thank you, Maritza. It's Jeanette Boyley. I'm the OT Regional Practice Lead. And I appreciate the functionality of this NPR.
Yeah, it's really, really helpful. And then just the other thing I just wanted to point out for all of our allied health folks here, as we kind of seen through the nursing demonstration, there is the table of contents. So if you need to review any specific information, results review is a great place to do that. Dennis did have the specific dialysis management flow sheet here, but there are a number of different flow sheets that you could leverage to view like information in chronological order. So I can click all results, anything kind of documented for my patient will be visible here. So just as a great way to review information documented by clinicians. And again, if you need to review any sort of labs or what have you, there's just the different tabs across the top here that you can click into. Unfortunately, I don't have like lab results, but then you get the drift that that information will be visible when you click on the tab. Okay. Sorry for the back and forth, guys. Okay. And then just for our dietitians, you guys are a little bit special because you guys have your own specific iView section or bands that you can document too. So I just took a screenshot of that. It's called nutrition care. So there's a number of different sections that you could utilize to support the work that you need to do. And similarly to the other allied health folks, you do also have your own nutrition services ad hoc folder, and then a number of different power forms that you can use, as well as specific dynamic document types specific to your position. Any questions there for the allied health folks? Hopefully that was a good kind of overview or review of what you could use in the system that's specific to your position. Okay, great. I'm just going to move on to downtime. I know we talked about this last time. So the one thing that we will stress from our team is that if you do not have a black or gray box of to where all your paper documents are stored, we would really encourage you guys to get that started. Here at PHC, we do have a professional practice person that's appointed to managing downtime for the whole organization. So I'm not sure if that's already been decided upon, but there should be a professional practice lead that you can refer to if you have questions for downtime procedures in general. So on your PD, in your unit, there will be a specific computer that is connected to a printer. There will be a sticker to denote that it's your 7/24 access downtime viewer. So in the event of any planned or unplanned downtime, when the systems are not accessible, you'll be able to navigate to this computer and view information about your patient. So it is information as old as up to 2 minutes and for 7 days. And any of your PD prescriptions are considered non-expiring, so they will be available across all encounters and also accessible through this Access Downtime Viewer. And then the one thing I just want to point out that's unique is that a lot of PD power plans are built out as day of treatment. So the only way to find that information when you do access the 7/24 computer is you actually have to find it through the Documents tab here. This is just a screenshot of what the 7/24 computer, like when you look and find information for your patient, will look like. And then from here, you'll be able to find the day of treatment orders. So that's just something to just call out for day of treatment power plans. And then the one thing I just also wanted to point out is that there is, we do have a CST Cerner help webpage with a lot of information to guide clinicians on what to do in the event of a downtime. And there's also frequently asked question guides and likely a shop policy that will be available for VGH. Okay. And then I'm almost done. I did want to talk through forms. So I'm not too sure what currently is happening right now in the PD unit, but at St. Paul's, after training, information is given to the patient in the form of a binder. So I'm not sure if you guys are doing the same thing over at VGH.
So for PD patients, they actually get a flip chart when they first start CAPD training with us. So it includes all the information for, it's actually much like what you have posted here. So it has all this step-by-step procedures for like hand hygiene, training, doing CAPD, and it also includes our contact numbers as well for both the unit, the hours, Allied Health, and Baxter.
Yeah, okay. So I think I just wanted to call out that because so many of the forms that you do provide your PD patients are from Baxter, as well as like from the BC Renal site. Not all those forms are available in our Forms Fast application that you could select and print. So I just wanted to call out that what potentially could be your future state is that whatever binder process you have likely will need to continue.
Yeah, just because like these specific flip charts that we have, like I think regardless, we'll still be distributing those just because it's easy for patients to follow the steps.
Yeah, exactly. Wayne, I noticed you're still on the line. I don't know if you wanted to comment on the binder.
No, we do the same thing where we have to create and print it all ourselves and make the binders and stuff.
I know we touched upon the BC Renal form, so how you currently are accessing it will likely continue in your future state. So I just listed a couple of the forms that are used. There's the BC Renal travel letter, PD Assist referral form, there's a caregiver like title care plan, and then the Baxter home dialysis product and services consent likely will still need to be accessed the way that you guys are currently doing now.
Maritza, I'm going to ask, is there a blood work one for PD? I'm going to show my ignorance now, like a power plan, power form.
For blood work? Oh, yes. So that was a request from Dr. Perkal to create some sort of power plan for your standing lab rec. Yeah. So we are aware of that, and we likely will address it in like a future upcoming order set session.
Okay, so that'll be in the order sets. Okay, so yeah, you guys, VGH will need the same thing. It's basically, instead of doing manual recs that you print out, it's just done through the power plan, you save it, and you print the recs out of there. So
yeah. I did want to talk. Yeah, no, for sure. I think it was highlighted, but I think due to limited resources, we weren't able to address it and build it out. So it's good that we're doing this design now so that we can get a power plan built out for both sites. The one thing I just wanted to ask the unit is when we were just reviewing the forms, I didn't see any sort of forms that you guys have in relation to PET test collection for your patients. Do you guys have a form of instructions that you give to your patients so that they know what to do if they need to do 24-hour urine collection?
Yes, we do have it.
Okay, are you able to send that over to us? We just didn't see it in our list of documents that we had originally collected from the unit.
Sure, we could send that.
Okay.
We'll send it.
I can scan it to the flow later. Yeah.
Okay, yeah, so then from Forms Fast, this is an application where we upload documents. The nice thing about that is when you do access it, the patient's information is available, like can be printed along, like kind of like your addressograph sticker. You don't have to put a patient label on it. But I did want to just mention that the PET collection instructions, we were able to upload them for St. Paul's here. So let me see if I can bring it up. I just don't know if it's maybe off the top of your heads if it's very similar to what St. Paul's has.
Hey, Maritza.
Yeah.
I also noticed on the form fast, like all the forms that are loaded right now are PHC or St. Paul specific. So is the plan to find the same forms that are VGH specific and get those uploaded, or are we trying to standardize?
Yeah, I think ideally we would like to standardize. So we might need to have more discussion to see if there are any similarities in the forms. I just wanted to bring up the form SAS application right now to show you guys, and then hopefully bring up one of the specific forms that are uploaded for PHC. What I'm assuming happened is likely only the St. Paul's forms were uploaded in form SAS to meet the needs of PHC Go Live. So that's probably why it's only St. Paul's there. So I'm just going to click on the PET form for CAPD. I'm just going to minimize that. So I'm not sure if this is similar to your current form at your VGH unit. Can you guys see that okay?
Is actually the same. It's just the format that is quite different.
Okay, so yeah, if we can receive copies of what you guys are currently giving out to your patients, then what we would suggest is having just one enterprise form that both sites would be able to use, and then that could be uploaded onto the Forms Fast application, and then you could print it off as needed. So this is that when you open it with the context of the patient, that information would be visible here, and you don't have to put a patient label on there, and it prints off nicely as one. Okay.
There's like those other forms on there on the list in that screenshot, like the log sheets and things like that. Like I'm pretty sure VGH has their own versions of all of those.
Okay. So yeah, if we can get a collection, then we can do an analysis and look for any gaps. Because ideally we want to recommend just enterprise like forms that are uploaded into this Forms Fast application, just so that it is available for all sites to use.
So, but then what that mean, we'll have to design a net new standard form, because the ones now, like the ones that are loaded now, even the one you just showed with the PET, it has St. Paul's information on it. So say if we say, oh yeah, we can use this form, it's the same, but all the fields and the information and the clinic information has St. Paul's information on there.
Mm-hmm. Yeah, so I think the Forms Fast group can help with creating any net new forms. So it would be a process that we'd have to go through, but we will need to do a gap analysis of the forms from VGH to see what the gaps or similarities are. Yeah. Okay. And that's kind of it for me in the slide for today's session. Did you guys have any questions? No? Okay. Just wanted to recap, we did have some action items, and we'll follow up on some good discussion that came out of this session, specifically around the CBC removal. We just need to iron out that process a little bit from an operations perspective to see how we can build out the orders in the system so they're scheduled appropriately, et cetera. We do have an upcoming scheduling design session on the 22nd. So just in regards to our discussion around follow-up orders, the PD IV infusion and the PET order, we can do a little more of a just like review and discussion there at that session. Our follow-up session number 2 is coming up in April, the 14th. And then we also booked a follow-up session number 3 to validate everything in May. And there is an order set gap review and order set design session scheduled for sometime in June.
Okay.
Well, great. Thank you so much. And if we can get those forms from you guys, that would be great. And then we'll follow up with Dr. Singh to see about the case conference titles, to see what she wants to be built into that order.
Okay.
Great. Thanks, everyone.
Thank you.
Thank you.
you.
Thank you.